Okay. So, may I have your attention, please? We'll have the laboratory exercise for urinary pathology together, and we'll start with some macroscopic images, both lesions and normal. So on the left, we have a section of the normal kidney. So what can we identify in this gross image? You see the renal sinus fat, which should always be checked when we have a renal cell carcinoma, because invasion in this fat increases the stage to T3. And what is this whitish tissue here that is observed? What is this tissue, this whitish tissue that forms the cavity in which the urine is accumulated? What is this? This is the mucosa of the, and Christos, please, shut the door and the window, please, because I don't want to have the lesson transmitted all over the place. No, only here. So what is this? Where there is a cavity, that's the pelvis, where we have the urine collected there. What is this? The whitish tissue. It's the renal pelvis mucosa. That means this is the urothelium. Okay? And we have the renal parenchyma, which consists of the medullary portion. Here are the pyramids with linear configuration. We have, because there we have the straight portions of the nephrons, and the renal cortex, which is of granular consistency, because there we have the glomeruli and the convoluted parts of the urinary tubules. So, as blood enters the kidney, we have the renal artery, which gives those interlobar arteries which go this way, in the close to the pyramids, and when they reach the margin between the renal cortex and the medulla, they become arcuate arteries. Then they go up the cortex as intralobular arteries and give the afferent arterioles to the glomeruli. We have the filtration of the blood and urine production, and then we have the efferent arterioles, which give the blood supply to all other parts of the nephrons, namely the urinary tubules and the interstitium. So, this is the blood circulation. The urine is produced in the glomeruli, then they go to the proximal convoluted tubules, which, well, when they go here in the pyramids, they become straight, and these are the thick descending portions of the Henle loop. After being thick, they become thin descending portion. Then they go up again in the pyramids, where the straight portions of the nephrons reside, and we have the thin ascending, thick ascending, and then when we reach the cortex again, we have the distal convoluted tubules, which come close to the glomeruli, and they have some specific cells named macula densa. And this is the juxtaglomerular apparatus, which controls the consistency and the amount of the urine and possibly secretes renin. That's why most renal diseases affecting the quantity and quality of the urine produced are potential causes of secondary hypertension, not the idiopathic hypertension, the common one, but nephrogenic hypertension. After the distal convoluted tubules, we have the collecting tubules and the collecting ducts, which go down here again, the calyces, and reach the PLO, the pelvis calyceal system, and thus the urine is there in the renal pelvis, and then we have the ureter or the urothelial lining spaces, renal pelvis, ureters, bladder, urethra. So that's the normal anatomy of the kidney. And here we have a normal kidney with these simple cysts, which are of no clinical significance unless they reach a very big size, and in some sort of trauma they may rupture. However, they do not affect the renal function, and it is a very common finding in adults. There is some sort of interest as concerns their differential diagnosis with cystically structured neoplasms. So what do we look by imaging? We look whether the wall of the cyst is thin, and we do not want the architecture to be complex. That means no septa dividing the interior of the cyst, and a homogeneous content favors a benign lesion. This is the case here, because these are 3-4 simple cysts. If we have complex architecture, we have to judge the blood supply. Why? Because most renal cell carcinomas have increased blood supply, so this will raise suspicions of cancer in conjunction with the complex architectures with septa dividing the interior of the cysts. These are signs of malignancy. Yes, please.
In the case of polycystic kidneys,
Polycystic kidneys, yes.
could this be like just
These are single cysts. They are not compatible with the gross image of the polycystic kidney, which we'll see shortly.
But it can't be, for example, like the first one. It can't be that big.
I think that they develop simultaneously, all of them. But there are two forms of the disease. The one inherited with the autosomic recessive, which is in the newborn. That means the cysts are present with birth. The other one, which is inherited by the autosomal dominant pattern, is there are no cysts in the newborn. However, when the patient reaches the adulthood, they develop, and gradually they replace all the kidney parenchyma. So, yes, please.
How does the malignant blood supply change?
What the blood supply?
The difference in the blood supply with the
Yes,
benign?
if a cystic lesion takes a lot of, has an increased blood supply, this favors that it is a cystically configured neoplasm, not a simple cyst. Because these tumors, renal cell carcinomas, as we discussed in our cases, have the stabilization of the hypoxia-inducible factor A pathway, and they have increased blood vessels, giving them blood. And this can be also used from a therapeutic point of view so as to control potential metastasis of this tumor. You give anti-angiogenic factors to block the blood supply of the metastatic renal cell carcinoma. So those were the simple cysts of no clinical importance generally. Next, look, this is the polycystic disease. You see that the whole parenchyma is replaced by these multiple cysts, which they are filled with a serous content, and the kidney weighs to increase the weight of the kidney increases very much. And normally it is about 150 to 160 grams. If we have the polycystic kidney, it may reach a weight of 2 kilograms and more. So this is one cause that leads patients either to transplantation or to hemodialysis. Here is another cause with all this granularity with shrinkage of the kidney, which means that here all these are microinfarcts. That means that this lesion affects the small arteries, the arterioles, the acroate arteries, the interlobular arteries, the afferent arterioles, by two clinically silent diseases that, if left untreated, they may destroy the kidney in this way. And do you remember which these diseases are that, if not treated properly, they cause this form of nephrosclerosis, meaning deposition of hyaline in the wall of arterioles and a thickening of the wall of arterioles. Which are these two conditions? Yep. Hypertension and diabetes mellitus. So, if not properly treated, they may destroy the kidney in such a way as the left image shows. And now we'll see the other cause that may destroy the kidney, which is in the middle. What do we see here? We see that the renal cortex is thinned. Look how thin it is by comparison to the normal kidney we previously saw. And you have all these distended areas. Here is the rhinosinuous fat tissue and distension of the ureter as well. And this dilation of the pielocalicial system, which may be related either to an obstruction by a stone or a neoplasm affecting the urine way, the way the urine goes. This is, by definition, consistent. Either it is an obstruction that causes it, or a reflux. That means the urine going backwards and distending the pielocalicial system. This is the hallmark of which disease? That may destroy the whole kidney. And if it is on one kidney only, you won't notice, because the creatinine levels will be normal, since the opposite kidney will function. And which is this disease? Which, when you have a stone, you should not just relieve the pain of the colic, because when the stone moves, it causes muscle spasm and it hurts. You have the colic pain. So it's not enough to relieve the pain. You have to look by ultrasound for possible dilations of the pielocalicial system, because if not treated properly, it may cause chronic pyelonephritis, the terminal stage of which is hydronephrosis. This is another category of diseases destroying the whole kidney in this way. Note that it is different from polycystic disease. Here we have multiple cysts replacing the renal parenchyma. Here we do not have cysts, we have cystical dilation, extreme dilation of the pielocalicial system. Here is a stone. You see the stone here? It has blocked the entrance of the ureter, and look how the whole kidney has been destroyed by severe chronic pyelonephritis with dilation of the pielocalicial system. And here signs of what? Look at this increased, this hyperemic region of the kidney. What are these signs apart from the dilation? What are these signs? You see that there are some parts of the renal pelvis are quite reddish in color, so you understand that this is
Or
Yes, it could be hemorrhage, but it is
hemorrhagic
it,
necrosis?
it is some sort of increased blood supply, because if you have stasis of the urine, here on a chronic base, of course, but what may develop there? Microbes. So these are inflammation. This is inflammation. And of course, we can have in our mind that chronic pyelonephritis results by recurrent episodes of acute pyelonephritis. That means infection. But that's not the only mechanism of chronic pyelonephritis. Chronic pyelonephritis on its own predisposes to infection because by definition there is stasis of the urine. However, obstruction is a main factor and reflux is another factor causing chronic pyelonephritis. But apart from this stone here, which has caused the hydronephrosis shown in the right image, we have another type of stone-related, somehow stone-related pathology of the kidney, especially when we have acute increase of uric acid in the patient's serum, as occurs when we have an increased destruction of cells, such as in a patient with leukemia who receives large amounts of chemotherapy and all the leukemic cells, the nuclei of all leukemic cells break, so uric acid is released and causes this very dangerous condition, the urate nephropathy, because all this uric acid goes to the urine and blocks the passing of the urine, and it is something like a stone, but not like the previous case, the one shown here on the right, where you have a much more common stone, which is composed of what? What is the main constituents of the majority? Calcium. So in cases you have stones, always you have to check if there is coexistent hypercalcemia. It's not always the case. Most times there is no hypercalcemia because the stones form due to a local increase of calcium in the urine. There are some cases, however, where you have hypercalcemia, possibly due to a granulomatous inflammation that causes hypercalcemia by the epithelioid histiocytes, which secrete a factor that activates vitamin D, also by hyperparathyroidism in the context of hyperparathyroidism where there is increased secretion by parathormone either due to hyperplasia of the parathyroids, primary hyperplasia, or by adenoma, a parathyroid adenoma, and very rarely a carcinoma of the parathyroids, and any other type that may cause an increase of calcium in the patient's serum. So, when we have a stone, you should always check the value of calcium in the patient's serum. If it is increased, look for the cause of hypercalcemia, because in this case, you treat the stone, and if you leave the hypercalcemia, another stone will form again. Yes, please. Want to ask me something?
No, I said
Okay.
breast cancer.
A metastasis from which cancer? Breast.
I think it was in another class we had that.
In that case, hypercalcemia might be due. If there is a metastatic cancer, hypercalcemia may be justified by the activation of osteoclasts by the metastatic cells in the bone and the absorption of the bone, which cause hypercalcemia. It is a potential cause of hypercalcemia, osteolytic metastasis. Osteolytic metastasis may raise the level of calcium in the serum. Yes?
Could the calcium level also have increased because of the hyperparathyroidism?
Yes, either in the case of primary hyperplasia of the parathyroid glands, more than one gland, or an adenoma. a neoplasm in the parathyroid. More common an adenoma, less common a carcinoma, which raises the calcium in crisis abruptly. Next. Here we have dilation of the pielocalicial system, of the renal pelvis mainly. Perhaps there is some sort of stenosis here, possibly congenital, and look how the whole surface of the kidney has been deformed, and this coarse scarring has deformed the shape of the kidney, and we can tell that this is a case of chronic pyelonephritis because the kidney appears swollen and deformed. In other cases, for example, chronic glomerulonephritis, remember from our cases that in the end stage, the kidneys are atrophic, they are shrinked. And the same applies to nephrosclerosis, either due to hypertension or diabetes mellitus. In chronic pyelonephritis, this is a typical image where you can see the scarring deforming the shape of the surface of the kidney. Look at the scars. And of course, a sine qua non, a prerequisite for the diagnosis of renal pyelonephritis is the dilation. Commonly by a stone or by some sort of congenital defect such as stenosis. Now, what has happened here? We see like a cyst-like lesion here, which is filled with this amorphous yellowish material. So, if you see a cyst that is filled with this friable material, what can this be? Pus, yes. So this is an abscess, And as you can think, how can an abscess be formed within the renal parenchyma? Yes, please. Ascending infection, that means due to the stasis of the urine, we have microbes development and they all go up and make abscesses. And the other cause is yeah?
I was going to say maybe from if the patient has bacteremia.
That's right, hematogenous spread. A patient has sepsemia or bacteremia, and by the blood, the microbes go and reach the kidney parenchyma, and they make some sort of very smaller microabscesses throughout the renal cortex mainly, the renal parenchyma. So these are the two causes of abscess formation. However, there is another lesion grossly detectable here. Can you tell me which part of the renal parenchyma has become necrotic here? This is very typical. See the pyramid? And the part of the pyramid, this is the pyramid, the medullary portion of the renal parenchyma. And see the part here that has become necrotic. And I'll explain again why this is such a vulnerable part of the kidney. Why? Because it is down the medulla, close to the calyces, so there is not enough blood supply even under normal circumstances. Because as we have previously discussed, all the urinary tubules, including the ones down the medulla, they expect to take blood from the efferent arteriole that leaves the kidney. So this area down there becomes hypoxic very easily, especially when there is inflammation. So in the context of acute pyelonephritis, all the free radicals of the inflammatory exudate may cause necrosis in this area, but there is also another cause of necrotic papillitis, because this area of the pyramids looking at the calyces are called papillae, renal papillae, and they become necrotic either in the context of acute pyelonephritis, especially in a diabetic patient who also has microangiopathy and there is not enough blood supply in the patient in the renal parenchyma, but also there is another cause of necrotic papillitis, which we have also discussed in one of our cases. On Monday, I think, we mentioned this cause, being which? That's a tumor. That's a tumor. It does not cause necrosis, because did you come, Hussein, on Monday? It's not necessary to come, just watch the video. You can watch the video and you'll catch up with the lesson, because here, as I many times told you, this is not a matter of compulsory. You do not have to be here. You must be here because you want to be here. That's something totally different. So, do you remember the case that caused necrotic papillitis? Yes.
The papillary urothelial carcinoma?
No, it doesn't have to do with cancer. Of course, if you have a carcinoma, it can become necrotic. But here, there is no neoplasm. It is a part of the renal parenchyma that becomes necrotic due to inadequate, insufficient blood supply. It can be caused by acute inflammation, yes, but it can also be caused by the use of which drugs? Remember the case? Yes. What is that? Acetaminophen, yes. Non-steroidal antiphlegmonoid. Yes. That's another cause of necrotic papillitis, which will have the similar gross image. Okay. Now, other gross images. Look at this. Look at how atrophic the one kidney has become because there was some sort of congenital stenosis of the relevant renal artery, which was not enough to block the blood supply abruptly so as to cause an infarct. However, being stenosed, there was not enough blood supply to the renal parenchyma on a chronic basis, thus it has become atrophic. What will be the presenting symptom of this young patient having a renal artery stenosis from his early years that will come to the doctor? What will be? It won't be renal insufficiency. Why? Because the other kidney is okay. So there will be no increase in urea nitrogen, no increase in creatinine levels in the serum, no decrease in creatinine clearance from the urine. What will be the presenting symptom of the patient with this atrophic kidney? What do you think? Why will he come to the doctor? To check what?
Maybe flank pain due to hemorrhage.
I'm not sure that there is hemorrhage in this pain. It just does not receive enough blood. So it does not produce enough urine. What endocrine system wakes up? The juxtaglomerular apparatus. And what does it cause? Nephrogenic hypertension. Because if we have a decrease in the urine production or in the contents of the urine, all cases involving the production of urine and affecting the kidney parenchyma are potential causes of secondary hypertension, nephrogenic hypertension. So he had increased blood pressure. He came to the internist, which was obliged to check the kidney, because especially in a young patient, it is not so common to have the idiopathic type of hypertension, which is much more common in adults of my age and even more. Yeah.
Is it common that these patients also have an embolism,
somewhere else.
I cannot understand the mechanism because if an embolus arrives and blocks the renal artery, the right image will appear. What is that? An infarct. You see? This is the result of infarction in the renal artery. On the left image, we have chronic ischemia. So we have atrophy, not enough blood supply, and nephrogenic hypertension. In the right image, we have acute ischemia due to embolism, which blocked a major segment of the renal artery. So what will the patient have? He will have pain, he will have hematuria, because there is coagulative necrosis in the kidney. And you look for a stone as the commonest cause of hematuria, no stone. You look for a neoplasm causing hematuria reaching the urinary tract, no neoplasm. What is the cause? An infarct. And which circumstances predispose to a renal infarct? Think, where can the embolus come from? Because now we have studied nearly all systems of pathology, so we can understand which patient is prone to develop such an infarct. And you'll also tell me why the infarct is pale and not hemorrhagic. Yes, please.
The first part would be someone with cancer.
Yes, if the patient has cancer, thrombi may develop and they may block mainly veins. Mainly veins. Here we have an arterial thrombus. Think where it may have come from. Think, where may it have come from? Yes, please. Directly from the left ventricle after an infarct, when a part of the heart does not move to send the blood, there is stasis in the left ventricle of the heart, and this predisposes to thrombi. One thrombus leaves the heart, enters the aorta, goes down the cilia carota, enters the renal artery and some big branch, a big branch of the artery, and this is the result. This triangular shaped infarct, which is of pale color. Why? Why is it pale and not hemorrhagic? Why? Can you tell me this macroscopic feature? Why is it a pale infarct? Yes, please.
That area doesn't have another source of blood.
Yes, there is no adjacent circulation. We have the acute blockage of the artery. This is the type of infarct. There is no adjacent circulation so that blood comes to the necrotic place from any other side, because renal arteries are terminal arteries. There is no branching. So a renal infarct is by definition pale. A cardiac infarct many times is pale. Sometimes when we have re-entrance of blood, it may be hemorrhagic as well. Bowel infarcts are commonly hemorrhagic because there is increased adjacent circulation in the branches of the mesenteric arteries. So that was the renal infarct. On the right, here we have neoplasms. You see that many neoplasms in the kidney are malignant despite their smooth margin. The margin is not infiltrative, at least from a macroscopic point of view. However, you see that it is somehow orange. This is typical of a clear cell renal cell carcinoma, and this tumor is of increased stage because it gave invasion in the renal vein. You see? So this increases the stage of the renal cell carcinoma. It's T3. Here we have also the yellow color characteristic of clear cell renal cell carcinoma, but we also have a whitish compartment of the tumor, which in this case is due to sarcomatoid differentiation. That means that the neoplastic cells have lost their differentiation. They look like spindle cells or rhabdomyoblasts. They resemble sarcomas. That's why we call it sarcomatoid, looking like sarcomas, despite being of epithelial lineage. And this increases the biological aggressiveness of the renal cell carcinoma considerably and should always be checked. And of course, we may have some invasion here in the perirenal fat. And here we have not a renal cell carcinoma, it's from a young patient, a child. We have a nephroblastoma, known as Wilms tumor. Here again, look at the kidney, look at the renal cell carcinoma, here also invading the renal vein, and please justify this macroscopic finding that the arrow shows. What is this reddish, dark stained tissue is? It is an organ that has a lesion. Which organ can this be? Which organ can this be? Taking into account the location. We have the kidney, we have the perirenal fat, and then we have that organ there which has a lesion. Which is this organ? Which is above the kidney? Which is this organ? What do you think? Edmund, which is this organ that stays up there? The adrenal, yes, the adrenal gland. And why does it appear thus hemorrhagic? What has happened here? It's easy to think. We see that the renal vein has been occluded by the cancer. You see the white arrow showing that part of the tumor which entered the renal vein. So it goes on up, trying to reach which vein will it reach after leaving the renal vein, the cancer? Which vein will be occluded by the cancer after the renal vein? Which one? Which is after the renal vein? And comes the inferior vena cava, and it will come to the heart. So, as ascending all these thrombus, which veins have been occluded? The ones taking the blood from the adrenal gland. So, what infarct is this one, which is as a complication of the tumor spread? What infarct is this? It's the hemorrhagic infarct, not the pale one we previously saw, the hemorrhagic infarct, which is caused either when we have vein blockage or when we have artery acute blockage, but there is adjacent circulation. In this case, we have a venous infarct, a venous occlusion by the tumor itself. And what do we see in the right image? We see multiple septa dividing a tumor with cystic formation. It's what I said previously, that when we have a cystic lesion in the kidney, we have to look whether its inside architecture is complex or not. Here it is, of course, too complex because you can see all these septa dividing the cystic spaces. You see all this cystic consistency of the tumor? So this is not a simple cyst, as we previously saw. This is a carcinoma, or a neoplasm better, because it is of very, very good prognosis, of the multicystic type of a carcinoma. It is a multicystic renal cell neoplasm. You don't call it carcinoma because it is too benign behaving. However, it is a neoplasm, not a cyst, not a simple cyst. And when you microscopically examine these septa, you'll find clear cell renal cell carcinoma cells. So this is a neoplasm with cystic configuration due to this complex architecture. Here is another neoplasm. It either invades the renal pelvis here, you see, all this granularity. The mucosa is not whitish as we previously saw and flat. It is of granular consistency. So it is either a tumor of the kidney invading the renal pelvis, or it is a tumor of the renal pelvis itself. In the latter case, how will you call it? How will you call a tumor that rises from the renal pelvis of the kidney? It is not a renal cell carcinoma because it does not derive from the renal parenchyma. It derives from the epithelial lining of the renal pelvis. So, how is it called? The urothelial carcinoma, because the renal pelvis is lined by urotheliums. You may not come, but you watch the videos and you catch up with the lesson. That's right. So everybody watches the videos and I'll stay at home and rest. I'll rest.
I had another lecture.
Eh?
I had another lecture.
Oh, no problem. I'm kidding. No, don't take it back. You come anytime you like. No problem. No problem. Okay? So this is a urothelial carcinoma, similar to the ones that form in the ureter, in the urinary bladder, urothelial carcinomas. And I want you to see all these neoplastic lesions in both kidneys, and there are also some cysts of no importance, simple cysts, but you see that some of the lesions have this sort of umbilication because of necrosis. If you see this image in both kidneys, what do you suspect? What is the first thought that this tumor is? Yeah.
I was going to say polycystic kidney.
They are not cystic, they are solid neoplastic lesions. Being multiple lesions, what's the first that you think? Yeah. Metastasis, yes. This is compatible with metastasis. Metastasis to the kidney, mainly from lung cancer, are reported, but they are not so common to see a metastatic lesion in the kidney. However, when you see these multiple necrotic neoplastic lesions, this may be compatible with another primary somewhere else, possibly in the lung. Now we finished the gross pathology. Unfortunately, we did not have specimens to show you yesterday, so now we'll go on to the slides. We'll see the slide of membranous glomerulopathy. You can open your virtual slides from the documents, down the documents in your e-class portfolio. We have all the links which open the slides. So let's see here the membranous glomerulopathy. Membranous glomerulopathy is an immune complex deposition related glomerulopathy. So I'd like you to see this glomerulus, and the same that will apply to this glomerulus will apply to all other glomeruli in the renal biopsy, and tell me, Now that we have done the lesson of glomerular diseases, last Friday, where nobody came, but that's no problem because we have the relevant video, so you can see the video and there will be no problem. So now that you have seen the video, you know how we judge the glomerulus. Do you think that this is a hyperplastic form of glomerulopathy? Do you see many cells either in the intracapillary compartment or the mesangium or the extracapillary compartment? Or is it close to normal cellularity? It's close to normal cellularity. So there is no increase in cells. This is not a hyperplastic type of glomerulopathy. However, we can see some diffuse, global, homogeneously thickened glomerular basement membranes, like here. Have a look at this one. You see that it is somehow reddish. You see the color? This is compatible with immune complex deposition. So, how can you tell that this is membranous glomerulopathy? You perform a silver stain which will stain the basement membrane and all collagen 4 containing structures black. And as the immune complexes press the basement membrane, it will appear, the basement membrane, the glomerular basement membrane will appear spikes, as spikes. And this is consistent with the established membranous glomerulopathy. As we said, perhaps if you see more than 3 cells in the mesangium, this could be a sign of mesangial hypercellularity. However, this morphological pattern being consistent with another type of immune complex mediated glomerulopathy might, yes? You could think of IgA nephropathy, however, immunofluorescence will be negative for IgA nephropathy. It will be positive for C3 and IgG, where in the basement membranes, not in the mesangium. So this pattern of immunofluorescence will reinforce the diagnosis of membranous glomerulopathy, and above all, the diagnosis will be confirmed by the clinical findings of the patient, which should always be told to the pathologist who examines the renal biopsy, and which is the syndrome most closely related to membranous glomerulopathy, which is the clinical syndrome that this patient will have and come to the nephrologist and take the biopsy. He'll wake up in the morning and there will be periorbital edema, also edema in the symmetrical edema in the limbs. There will be a decrease in albumin and the total protein content in the blood. And all this, how is this syndrome called? How is it called? Nephrotic. This is the nephrotic syndrome. So we have nephrotic syndrome, we have positive immunofluorescence. That means we have granular, diffuse, global immunofluorescence. So it is immune complex deposition related, and it is not some sort of podocytopathy, because there are 2 podocytopathies having nothing to do with immune complex deposition, which could justify a nephrotic syndrome. Which are they? Which are the podocytopathies which are negative or non-specific in immunofluorescence and could give nephrotic syndrome, could cause nephrotic syndrome to the patient. Which are they and should be excluded here, both based on immunofluorescence positivity findings and some other things here that I'll tell you. Do you remember the podocytopathies? that cause the nephrotic syndrome is minimal change disease and focal segmental glomerulosclerosis. However, none of them gives granular immunodepositions in immunofluorescence, so they are excluded. This is how the membranous glomerulopathy is diagnosed, and another feature for the nephrologist is to define whether the membranous glomerulopathy is primary or secondary. That means, of course, it starts from damage in the glomeruli, but does the kidney participate in a systemic disease, or is it only a disease on the kidney? And which factors, systemic factors, may be related to the development of membranous glomerulopathy? Name some factors that give the secondary type of membranous glomerulopathy. Cancer patients, and I think, if I'm not mistaken, hepatitis B virus antigenemia are potential factors related to membranous glomerulopathy. But you'll check it up in your textbooks. Of course, yes, one type of lupus nephritis is membranous glomerulopathy. However, we'll have the antinuclear antibodies, which will justify the diagnosis of lupus, and we will have a full house immunofluorescence positivity. That means deposition of IgA, C1q, C3, IgG, IgM, everything is deposited in lupus nephritis. Is there anything else we have to see here in the membranous glomerulopathy? As we are having the lesson now with live transmission, these slides are for the end term practical exam, so you can study them in the respective videos. Okay, that was the glomerulopathy, membranous. All glomeruli have a homogeneous diffuse global thickening of basement membrane due to immune complexes deposition, like here. If we had performed a silver stain, we would have observed the spikes. Next, this is kidney removed with chronic pyelonephritis. I want you to find this part of the renal parenchyma, and apart from the inflammation with all these newly formed blood vessels, and I see a mononuclear infiltrate, thus telling me that inflammation here is chronic or acute, since it's chronic inflammation. But I want you to understand where it all starts, where inflammation begins, because it begins at this site of the kidney. And what do you see here? You see a stratified epithelium and a cavity. This is the cavity. You see the new offers, now that Black Friday has ended. You have to wait for the February discounts, the sales. Don't be angry with me. Don't be angry. Don't be afraid. Don't be angry. I'm just joking. No problem. No problem at all. So what was I saying now? Yes, did you understand? Do you know the part of the kidney where we have the cavity, where the urine is gathered, and we have this mucosal epithelium which is stratified? Do you know how this is called? How much do they charge you for this? It's a very nice, you see, it's a very nice. Merry Christmas, it's very good, very, very nice. But it's cold. Yes. You drink cold coffee now?
Yes.
Oh, no. I have hot now. So, know which part this? Which part of the kidney is this? Lining. So, it's easy. It's pyelonephritis. So, it's the renal pelvis. And how do you call this epithelium? Lining the renal pelvis? That's right, it's the urothelium. It lines the renal pelvis, the calyces, the renal pelvis, the ureters, the bladder, and part of the urethra. So, inflammation starts from there. And what are the main causes of chronic pyelonephritis? Yes, please?
Ascending bacterial infection.
This is the consequence. The cause is, yes, ascending bacterial infections, yes, but mainly obstruction by a stone or a neoplasm somewhere in the urinary tract, and reflux, possibly a stenosis causing reflux, or a neglected prostate hyperplasia, where we have stasis of the urine in the bladder, and this becomes more and more and more, and then we'll have bilateral chronic pyelonephritis. Okay, so that's where it all starts from. We saw lymphocytes compatible with chronicity, and there are some other signs of inflammation. Have a look here. Now, here is another part of the pelvis, very dense lymphocytic infiltrates, and we have some follicles, lymphoid follicles. It is very dense, but let's see the consequences that justify the end-term disease. Look here. What sort of tissue has developed here in this field which is compatible with chronic inflammation? What is this tissue here? Yeah, fibrous tissue. Remember, I shown you the disfigured gross image from the kidney. This is the tissue that caused the disfiguration. The scar tissue, which is a consequence of chronic persistence of inflammatory cells. So, we have this coarse scarring tissue. Next, what are these structures here which are so little and they have all this thick material in them that looks like colloid in thyroid follicles? It has nothing to do with it though. And furthermore, what are these here? What are these structures here, the wall of which is so greatly thickened, taking into account the diameter of the structures? For example, look here. Is there a seat for me? Oh, yes. So, all right. What are you watching? What are you watching? I see. No, anything you like. You do anything you like. However, I thought you were watching. You go this way, and look at this. Okay? You look at this part, or the central one. Excellent. So, let me have a seat, because after 1.5 hours, I'm a bit tired with the lesson. I'm not so young anymore, so I'm a bit tired. Okay. So, let's sit here and have a chat. Now, look here. There are some structures, you see that they have a lining that looks like epithelium. However, they are small ones. What are these structures in the normal kidney parenchyma? How will you call these structures? They are glandular structures having this sort of epithelium and the lumen. What are they? What are they? Are they glomeruli? No, we do not see the tuft. What can they be? Which part of the renal parenchyma is? Yeah? There? Yes, but that would have a tuft, the urinary space, and the Bowman's capsule. These are glandular structures. They are epithelial structures of glandular epithelium. What are these structures called in the kidney? Do you want me to identify them and learn them? Yes, they are urinary tubules. So they have become shrinked and atrophic. That's why they are so small. And how is this justified? This is justified by what the mouse shows us. You see these structures here, that they have a lumen as well, However, what are these cells in the lumen? You see these reddish cells here in the lumen of these thickened structures? What can they be? Red cells, red blood cells. So what structures are these that have a lumen and red blood cells in them? What structures are these? The blood vessels. So what is abnormal now? They are greatly thickened. How can this be justified? Why are these small vessels of the kidney thickened thus much? It's not a matter of hypertension, as we had discussed. It's not a matter of nephrosclerosis due to hypertension or diabetes mellitus. Something else caused the thickening in these arterioles walls. What is that in this context? What is that? It is not hypertension. It is not diabetes mellitus. What can... That's right. It's chronic inflammation, because due to the chronicity of the inflammatory exudate, the lymphokines secreted by the lymphocytes cause the obstructive endarteritis. That means in chronically inflamed tissues, the walls of the vessels become thickened. And what is the consequence of this? What can this justify? It can justify the atrophy of the urinary tubules. Why? Because the urinary tubules expect what will come out of the glomerulus, the efferent arteriole, to give them blood supply. Let's have a look at the glomeruli, which, not receiving properly adequate blood supply, look what has happened to them. This one is okay. What about this one? What can this part, this hypocellular part of the glomerulus, what tissue has formed there? How do glomeruli respond to a chronic ischemia? What happens within them? Yeah, fibrosis. So they do not take enough blood supply, they become fibrosed. So they do not send enough blood to the urinary tubules, which thus become atrophic. That's why I told you all parts of the nephron cooperate with each other. Here we had a disease that started in the tubulointerstitial compartment. We had the chronic cells of chronic inflammation, of chronic pyelonephritis. However, they affected the vessels secondarily. The vessels of the interstitium were secondarily affected. They were thickened. The glomeruli did not receive enough blood supply, so they were fibrosed, and this caused the atrophy of the tubules. This is the mutual dependence of all parts of the renal parenchyma. So we saw all that damage here due to chronic pyelonephritis. Here are other atrophic tubules with flattening of the glandular epithelium lining them. Let's have a look if there are any other lesions in the slide. Again, atrophy of the tubules here, thickening in the wall of the arterioles and small arteries. And have a look at this glomerulus. This is fibrosis along Bowman's capsule. You see that the Bowman capsule has become thickened and fibrosed. This is a secondary phenomenon, nevertheless. Here we have a lymphocytic infiltrate, chronic inflammation, another site of atrophic tubules. What do they look like? They look like thyroid follicles. They have nothing to do, of course, with the colloid we observed in the previous semester that we had endocrine pathology. This is some sort of atrophy. Bless you. What is this? This is a glomerulus with Bowman capsule fibrosis. And this is one which is globally sclerosed, globally hyalinized. So that was the slide of chronic pyelonephritis. Here we have another type of inflammation which affect a kidney transplant. What's going on here? Look, can you identify this structure within the renal parenchyma? Look, it has a muscular wall. You see the muscular wall? And however, you cannot see the lumen because the inner layer has become greatly thickened due to this accumulation of cells. What can this be? Look, what can this be? Quite a big structure which should show a lumen. Not possible here due to all these cells accumulation. Can you guess? And this is a renal transplant that it was rejected. That means, despite the immunosuppression the patient received after surgery, no, it did not respond, and the patient did not have enough urine, creatinine levels raised. They performed a biopsy. The nephrologist performed a biopsy from the transplant, because what information did he want me to tell him? Is it acute tubular necrosis, the cause of oliguria? No problem. It will resolve on its own. Is it some sort of acute infection? In that case, we could see neutrophils in the renal parenchyma, and it would be a matter of giving proper antibiotic therapy. Or is it rejection? Because in case of rejection, you have to give immunosuppressive therapy. Think that the patient has acute pyelonephritis, and you think that it is acute rejection, and you give immunosuppression therapy. What will the inflammation do? It will grow. So that was the purpose of the renal biopsy. So what's happening here? What is this structure being invaded by these immune cells? Yeah, an artery. This is vasculitis. This is vascular rejection, which is some sort of acute rejection. Here is on a chronic rejection base, anyway, that it is quite severe. It's not the same time of rejection if you just see dense lymphocytic infiltrates. And by the way, which subtype of lymphocytes do you expect to predominate in the rejection response? Which type of lymphocytes? T cells of which subpopulation? T? Cytotoxic cells, yes. T8, CD8 lymphocytes. Okay, now, this is vasculitis. Yes, please?
We are certain that this is a question that is not the ureter because it's more ureter is bigger.
This is part of the renal parenchyma, not the ureter.
If we have the lower part, the start.
No, if you take a biopsy, you check the cortex.
Okay, always.
That's the representative biopsy. You check the cortex. So, here is, let me have a look at another type of rejection which is less severe and is this type in which you see immune cells entering the epithelial of the urinary tubules. When we see more than 3 lymphocytes in the epithelial of the urinary tubules, this is called tubulitis, and this is a form of interstitial rejection, not so severe as the vascular injection. Here, both types of rejection coexist. We saw the vascular rejection, and here we have the tubulo-interstitial type of rejection, which is defined by dense lymphocytic infiltrates and entrance of lymphocytes within the epithelium of the urinary tubules. Let's see the rest. Here we are. What is this structure being invaded by all these cells, some of which are neutrophils, because when some cells are destroyed, neutrophils may come. However, it is an immune-mediated inflammation. What is this line here, which is quite continuous and defines the layers of this? What happened? What happened here? Christo, τι έχει? What is it looking? I'm not only the only. Yes, at last. Sorry, no next slide. We have to. You have my sympathy because we have to stop the lesson. Stop the lesson now. Can stop the lesson. I have 1/4. Ah, it came back. Here I am. Yes, it's the lamina, the elastic lamina of the arteries. Yes, and you see that all these cells have the this is vasculitis again, vascular rejection. And what is the hallmark of vasculitis? What can all these quite dark staining areas be in an inflamed vessel? What type of necrosis is this? It is in vasculitis, in fibrinoid necrosis. That's what happens in vasculitis. So we saw another artery. Here is a tubule, and we have all these rejection. However, there is another type of rejection, which is, however, only immunohistochemically defined, and it has to do with C1q immunopositivity. This is humoral rejection, which is quite severe. This is cellular rejection, but I'm not so sure that the transplant would be okay, because it has a severe vascular type of rejection. This is vasculitis. Yes, please?
So this is host versus graft.
Host?
Versus host, right?
No, this is the transplant that entered the patient. The patient is the host versus the transplant. Yes, this is rejection. It's not graft versus host. Yes. Now, we have some tumors now. 2 of them. This one is the clear cell carcinoma, renal cell carcinoma. Let's have a look at its main characteristics. Here it is, clear cells, crystal clear cytoplasm, and we have these complete fibrovascular septa separating the axini of cancerous cells one from the other. this is a very typical morphological image of conventional clear cell renal cell carcinoma, and the main immunohistochemical marker of positivity in this cancer is carbonic anhydrase 9. Why? Because it is related to the stabilization of hypoxia-inducible 1A factor, which is crucial in the pathogenesis of renal cell carcinomas, and the responsible gene which is inactivated and gives rise to this tumor is which one? Which oncosuppressor gene is inactivated and leads to renal cell carcinogenesis? You remember the gene? It can be also involved in a hereditary type of cancer. However, in sporadic cases of clear cell renal cell carcinoma, it is responsible, which is this tumor suppressor gene that we have discussed in our cases. It's just last Monday that we mentioned it. Just last Monday. Not 2 years ago, 2 days ago. It's von Hippel-Lindau. All right? Von Hippel-Lindau. That's the syndrome. And it is the respective gene. So, we have to grade the tumor, and the grading of renal cell carcinoma has to do with under which magnification we can identify a nucleolus in the cancerous cells. If we need a high magnification to find the nucleolus, the tumor is low grade. However, if we can see the nucleoli in the nuclei of clear cell carcinoma cells under a 100 magnification, meaning a 10 lens, this is high grade. As far as the present specimen is concerned, nucleoli are not so apparent, so it appears to be a low grade renal cell carcinoma. You see how hemorrhagic is, having to do with the rich blood supply. You see, despite being a carcinoma, how well circumscribed it is, despite being a carcinoma. Here are the acini. The acinar pattern is the most common one. However, there is also a tubular pattern observed here. That means that cancerous cells form tubules. And here we have the tumor adjacent parenchyma, which is somehow compressed by the tumor and consists of the normal structures of the renal parenchyma. Please identify the normal structures because we have to revise histology as well. What do you see here? What are the normal structures here in the tumor adjacent parenchyma? What structures are these? These. The glomeruli. All right. The other ones? The tubules. It's that simple. We have the proximal tubules with well-established brush border because they reabsorb the urine, and the distal convoluted tubules because we are in the cortex. We see glomeruli. We are in the cortex of the kidney. And the distal convoluted tubules have a sharp luminal surface. The proximal convoluted tubules have the brush border there. And there are some other slides of renal cell carcinoma. Let's see if they are different. Yes, there is a difference here because many cells do not have, there is clear cytoplasm. Okay, there is a crystal clear cytoplasm. I'm not sure there is something different here to tell. The complete fibrovascular septa separating the groups of malignant cells. And the other one, this one, is quite different despite being a clear cell renal cell carcinoma? Ah, yes, this is different. And it's very easy to say why it is different, because many cells have a granular cytoplasm. So, if we have a subpopulation, or even the predominant population of cancer cells having a granular type of cytoplasm, we also need immunohistochemistry to define it as a clear cell carcinoma. Why? Because it is not clear. It has granular cytoplasm. So we perform carbonate anhydrase 9 immunostaining. If these granular cells are positive, we diagnose this as a clear cell renal cell carcinoma, despite that the cells are not clear everywhere. And when this component of granular cells with eosinophilic cytoplasm predominates, we must tell the clinician, because if he gives immunotherapy in case of metastatic disease, then the results will not be so promising. When the tumor consists of more than half of its cells with this appearance of the granular type. However, the diagnosis does not change. It is a clear cell renal cell carcinoma, which is the commonest type of renal cell cancer, and the prognosis is not so good as in some specific subtypes of renal cell carcinoma, the papillary renal cell carcinoma and the chromophobe renal cell carcinoma. These are two rather common subtypes of renal cell carcinoma where we have a somehow better prognosis. This is not so good, the prognosis is not so good in this tumor. It is a clear cell renal cell carcinoma, and I can see, as I can judge from the nuclear pleomorphism, it is more probable to be of a high grade. High grade. Okay. The last tumor is a tumor mainly of young children, and this is Wilms tumor, being composed of three components. This one with these cells, spindle cells, is the mesenchymal component. Here is the more undifferentiated component, the blastema component, and here we have another component which consists of these structures. Can you tell me what this component is based on the morphology of the structures? What do you see? You see lumen in the structure. So what structures are they? The third component of Wilms tumor, of nephroblastoma, a common kidney tumor, mainly in infants. What is this? Since it makes lumen, what structure is it? Tubules, so it's epithelial, the epithelial component, yes. And some of these, have a look at some of these tubule-like structures. You see these projections in the lumen. You see the projections? What do they look like? Because I'm sure that you are very strong on embryology. That's for sure. What is this projection like in this lumen? It has the epithelial lining, and there is some projection there in the lumen. Think of embryology in the development of the kidney. What are these structures? Primitive, they are primitive structures of what in the adult, in the kidney of the newborn and the adult? Which structures form this way? You have an empty space lined by cells, epithelial cells, and you have a projection that gradually becomes a tuft. So, what do they look like? They look like primitive what? No, that's too primitive. That's in the tumors in yolk sac. Yes, which part of the nephron makes a tuft?
Calyces of the body.
No, because calyces have urothelial. Yeah, glomeruli, yes. These appear like primitive glomeruli. Not all of them, not all of the structures. I'll show you which. This one. You see the projection? This one. This one. It's how the glomeruli is formed, as you already know from embryology. You already know. It's not a matter you just pass the exam. It's what you learn. That's what I keep telling you. But it's up to you. I don't want to exert too much pressure. It's not good. No. You are free to do as you like. But I have to say something that I think I have to tell you, because since we have such a close relation all this year, I feel that I know you. So I have to tell you. Of course, I say to everybody, despite the fact I know him or not, that's different. However, for you, one for more reason is that because I try to communicate with you. I'm sure that you have understood that during our cooperation here. If you do not communicate and you just sit there, listen to the lecture, then we have the questions. It's not about you. Then we have the question. Then we pass the exam. This is not education. This is distance learning. Distance learning. You have the distance learning and you have a question. Oh, sorry, I'm cooking now. No, I've just taken to get the kids from the karate lessons. Is this learning? You are connected to the lesson and you do anything else apart from paying attention to the lesson. So let's be serious as far as medical education is concerned. If you have other types of education and you want to become some sort and have statistical analysis of the popularity of politicians and that, okay, you can do as you like, no problem. It's not necessary to be serious. It's okay. But medical education, you're not serious here, you lose the patients. And what else can we see in the nephroblastoma? We can see this structure, that it is above the kidney. What is this? This is the adrenal. It was removed with the kidney having the nephroblastoma. This is the adrenal gland, the cortex, with the zones you know from histology. So that was the nephroblastoma. And there is another section of nephroblastoma. It mainly has the mesenchymal component with the spindle cells, the undifferentiated component, here it is, the blastema component, and some epithelial structures. Here, the epithelial component of the Wilms tumor, which expresses the respective immunomarker, WT. Wilms tumor. That was the case of the nephroblastoma. So I think we've finished all our slides, and that's the end of our laboratory exercise on urinary pathology. Thank you.